Welcome to MedEd 360. In this video, I will cover everything you need to know about the rheumatoid arthritis, including its pathogenesis, diagnosis, classification criteria, and treatment. Whether you are a medical professional or just curious about the disease, this will be a clear and detailed breakdown. So stay tuned. And if you find this content helpful, don't forget to like, subscribe, and hit the bell icon for more medical insights. So, rheumatoid arthritis, or generally called RA, it is a chronic systemic inflammatory disease of unknown etiology, primarily affecting the synovial tissues of the joints. In most cases, it is associated with elevated serum autoantibodies, including rheumatoid factors and antibodies to the citrullinated peptide antigens. The primary site of pathology is the synovium, where persistent inflammation leads to synovial proliferation and formation of the pannus. This invasive tissue then gradually destroys the cartilage, bone, and ligaments, resulting in joint damage and deformities. Although the joints are the main target, systemic inflammation is believed to contribute to various comorbid conditions, including cardiovascular disease, osteoporosis, cognitive dysfunction, psychiatric disorders, and even certain malignancies. Understanding this broader impact is essential for the comprehensive management of rheumatoid arthritis. Now let's talk about the epidemiology of rheumatoid arthritis. RA is a global disease with variable geographic prevalence, affecting approximately 0.5 to 1% of the adults. It is 3 times more common in women before menopause than in men, highlighting a possible hormonal influence. While RA can occur at any age, its incidence is higher in women, with an annual rate of about 40 per 1 lakh compared to 20 per 1 lakh in men. Understanding these patterns help in recognizing at-risk populations and guide early diagnosis and management. Moving on to the genetics of rheumatoid arthritis, it has a strong hereditary component with an estimated heritability of about 60%. This means that genetic factors play a significant role in determining the susceptibility, though environmental triggers are also involved. The most well-established genetic risk factors are the HLA-DR alleles, particularly the HLA-DRB1 variants like the DRB1 0401, 0404, and 0101. These alleles are associated with the shared epitope hypothesis, which suggests that certain amino acid sequences in these genes contribute to the autoimmunity and disease severity. Beyond the HLA genes, several non-HLA genes have also been implicated in the RA development, influencing the immune regulation and inflammation. Similarly, epigenetic factors are likely to play a role as well. These are changes in the gene expression that do not alter the DNA sequence but can influence disease risk. Key epigenetic mechanisms in the RA include altered DNA methylation, histone modifications, and microRNA expression patterns, all of which contribute to increased inflammation. So this was a brief discussion of the genetics involved in the development of RA. Okay, now let's discuss the etiology of rheumatoid arthritis. Increasing evidence suggests that environmental factors play a significant role in the development of RA. Among these, smoking has the strongest association with a well-established link to increased disease risk. In fact, smoking cessation is the only modifiable risk factor proven to reduce the likelihood of developing RA. Other environmental factors include exposure to silica, obesity, and vitamin D deficiency, all of which have been implicated in RA risk. Infectious triggers are also suspected to contribute to the disease onset. Bacterial infections, including those caused by mycobacteria, mycoplasma, streptococcus, E. coli, and Helicobacter pylori, have been implicated. Viral infections such as rubella, Epstein-Barr virus, and parvovirus have also been associated with RA development. Interestingly, some evidence suggests that low levels of alcohol consumption and the use of estrogen-containing oral contraceptives may have a protective effect against RA, though the exact mechanisms remain unclear. Let's summarize what we have learned so far. Rheumatoid arthritis develops due to a combination of genetic predisposition and environmental triggers. On the genetic side, certain HLA-DRB1 alleles, other HLA variants, and non-HLA genes contribute to the susceptibility. However, having these genetic factors alone is not enough to initiate the disease. Environmental triggers play a crucial role in the disease onset. Potential triggers include smoking, bacterial and viral antigens, and some other unidentified factors. When these triggers interact with a genetically susceptible individual, they can initiate an abnormal autoimmune response. This ongoing immune activation leads to the synovial proliferation, pannus formation, and ultimately joint destruction, which defines the clinical course of RA. Okay, so now let's discuss a very important aspect of rheumatoid arthritis, that is its pathogenesis. Imagine your body turning against itself, slowly breaking down joints, bones, and even other tissues. In simple terms, that's exactly what happens in RA, but how does this inflammation even begin? So let's break it down step by step. The development of RA occurs in various stages, and the first one is the pre-RA phase. Consider it like a silent invasion. One would believe that the RA would start in the joints, but that's not true. Actually, RA starts in the lung, mouth, or gut. Strange, right? But that's true. Environmental triggers like smoking, infections, or irritants set off an immune response, and the body loses tolerance to its own proteins, especially those modified by a process called citrullination, where an enzyme alters certain proteins, making them look foreign to the immune system. In response, the immune system mistakenly targets these citrullinated proteins found in the collagen, fibronectin, and other tissues. This leads to the formation of autoantibodies, specifically the rheumatoid factor and the antibodies against citrullinated protein peptides, which are the key markers of RA. After the pre-RA phase comes the transition phase, in which the fire is ignited. At this stage, the RA moves beyond autoantibody formation. The immune system goes into an overdrive. The B cells, T cells, and inflammatory cytokines like TNF and interleukin 6, they flood the bloodstream. Inflammation surges just before the symptoms appear. As a result, synovial revascularization increases and immune complexes begin depositing in the joints. This is the moment when RA transitions from an immune system imbalance to a full-blown joint disease. After that, the joints are under siege. Once the RA reaches the joint, the real destruction begins. The synovium thickens, packed with macrophages, T cells, B cells, mast cells, and fibroblasts. And this hyperactive immune response leads to the fibroblast-like synoviocytes attacking the cartilage and osteoclasts breaking down the bone. Macrophages and inflammatory cytokines keep fueling the destruction, ensuring the process is relentless. So the RA is affecting the joints, but that's not all. RA is felt beyond the joints as well. The whole body feels the heat of RA. RA is far more than just a joint disease. It's an immune system rebellion that affects the entire body. The heart and the blood vessels suffer, leading to an early atherosclerosis and increased risk of MI. The bones become fragile due to chronic inflammation, leading to osteoporosis. And the brain is also affected, contributing to fatigue, depression, and cognitive decline. So, in reality, the RA isn't just about swollen joints. It's a systemic inflammatory disorder with widespread consequences. But the more we understand about its pathogenesis, the better we can develop targeted therapies to fight back. So, to summarize, the rheumatoid arthritis begins with systemic immune dysregulation, possibly triggered in the lungs or mucosa, leading to autoantibody production, cytokine-driven inflammation, and synovial infiltration by the immune cells including T cells, B cells, and macrophages. All of this results in ultimately causing the joint destruction, bone erosion, and systemic complications like atherosclerosis and osteoporosis. This was all about the pathogenesis of rheumatoid arthritis. And if you are still here and learning from this discussion, kindly like this video, subscribe to the channel, and share it with others who might find it helpful. Your support helps us bring more valuable medical content your way. Thank you. Alright, let's talk about the clinical features of rheumatoid arthritis. So, how does RA present? Well, the presentation can vary, but in most cases, it starts gradually. You won't wake up one day and suddenly have a full-blown rheumatoid arthritis. Instead, over weeks to months, patients develop symmetrical joint pain, stiffness, and swelling, primarily affecting the small joints. Now, here's an important hallmark: morning stiffness. This is what really sets inflammatory arthritis, including the rheumatoid arthritis, apart from non-inflammatory arthritis. Patients often wake up with stiff, achy joints that feel locked up, especially after long periods of rest, whether it's after a full night's sleep or even just sitting still for a while. Unlike the osteoarthritis, where movement makes things worse, in RA, the stiffness actually improves with activity as the joints gets moving. So, in summary, slow onset, symmetrical joint involvement, persistent morning stiffness, and improvement with movement. These are the key red flags that should make you suspect RA in a clinical practice. Okay, let's talk about the systemic features and the extra-articular manifestations of rheumatoid arthritis. While arthritis is the primary feature, rheumatoid arthritis is much more than just a joint disease. In most cases, the arthritis has a slow, insidious onset, but in some patients it can be fulminant, developing rapidly. Others may initially present with monoarthritis involving a single joint or oligoarthritis affecting a few joints for a prolonged period before progressing to a more typical symmetrical polyarthritis. Fever, fatigue, and weight loss can accompany the joint symptoms, making the RA more than just a musculoskeletal disorder. These systemic symptoms are driven by the underlying chronic inflammation. Apart from these systemic features, patient may also manifest extra-articular features. Not all patients develop extra-articular features, but they are more common in men. The most affected systems include lungs, which can present as interstitial lung disease, pleuritis. It can affect the skin, presenting with rheumatoid nodules or vasculitis, or it can involve the eyes, scleritis, episcleritis, etc. So, when evaluating a patient with suspected RA, it's crucial to look beyond the joints and assess for systemic and extra-articular involvement, as these can impact the prognosis and the management. Moving forward, the RA has a very specific pattern of joint involvement, which helps in distinguishing it from other types of arthritis. Early in the disease, the RA targets small joints, especially of the hands. That includes metacarpophalangeal joints and the proximal interphalangeal joints. It also involves the joints of the feet, like the metatarsophalangeal joints. As the disease progresses, it spreads to larger joints in the following general order: wrists, knees, ankles, hips, and shoulders. These large joints are usually involved later on. Less commonly but important joint involvements are temporomandibular joints, cricoarytenoid joints. Involvement can lead to voice changes and breathing issues. And lastly, the sternoclavicular joint. The rheumatoid arthritis can affect the upper cervical spine, particularly the C1-C2 atlantoaxial joint, which can lead to instability and neurological symptoms. However, unlike other spondyloarthropathies, the RA rarely involves the rest of the spine, making this a distinguishing feature. Understanding this characteristic joint distribution is crucial for recognizing the RA early and differentiating it from other types of arthritis. Now let's focus on the hands, because a significant portion of the disability in RA comes from the hand involvement. RA typically starts with swelling of the metacarpophalangeal and the proximal interphalangeal joints, which leads to stiffness and pain. However, the distal interphalangeal joints are almost never involved. So, if you see a significant distal interphalangeal joint involvement, think of other diagnoses like osteoarthritis or psoriatic arthritis instead of RA. As the disease progresses, the hand starts developing classic deformities due to ongoing joint damage. The metacarpophalangeal joints gradually drift outwards, leading to the characteristic ulnar deviation. Other deformities like swan neck deformity, where the fingers bend at the base and the tip but hyperextended in the middle. Boutonniere or buttonhole deformity, where the middle joint flexes while the tip hyperextends. And Z deformity of the thumb, which alters the normal alignment of the thumb. If RA remains active and uncontrolled, the hand function deteriorates significantly, leading to major disability in daily activities. This is why early diagnosis and treatment are so important in preventing the long-term damage. I have talked about the hands. Now what about the feet? Feet are also very commonly affected in the RA. In fact, the metatarsophalangeal joints are often involved early in the disease and are often one of the first sites where the radiological erosions appear. As the RA progresses, the structure of the feet starts to change. One of the most noticeable deformities is hammer toes, where the toes become permanently bent at the middle joint. Another important complication is subluxation of the toes. This means that the joints become partially dislocated due to ongoing inflammation and damage. As a result, the toes shift out of place, leading to skin breakdown and ulcers on the top of the toes, as well as misalignment of the metatarsophalangeal heads, making walking painful and difficult. This involvement of the feet not only affects mobility but also contributes significantly to disability in RA patients. The wrist joints are also involved in most patients with rheumatoid arthritis. Even early in the course of the disease, synovial proliferation in and around the wrist may compress the median nerve, thereby causing carpal tunnel syndrome. Later on, this synovial proliferation may invade tendons and lead to rupture, most commonly of the extensor tendons. After the small joints, let's move on to the large joints like knees, ankles, hips, and shoulders. In rheumatoid arthritis, these joints are characteristically affected symmetrically, meaning both sides of the body of the joint are involved in a similar pattern. For example, let's look at this X-ray of a knee joint. You can see a symmetrical joint space narrowing, meaning that the cartilage loss is happening evenly across the entire joint surface. This is a key feature of rheumatoid arthritis. Compare this with an osteoarthritis where the joint damage is often asymmetrical, meaning that one side of the joint gets worn down more than the other. This difference is an important clue when distinguishing between rheumatoid arthritis and osteoarthritis on imaging. Another important aspect that needs to be discussed is the involvement of the cervical spine, which is one of the few parts of the axial skeleton affected by the rheumatoid arthritis, particularly the C1-C2 joint, atlantoaxial joint. Over time, the bone erosion and ligament damage can occur, leading to subluxation, which means that one bone shifts out of its normal alignment with the other. In most cases, the C1-C2 subluxation is mild and doesn't cause any symptoms. However, it's important to be careful when positioning the neck, especially during medical procedures or chiropractor manipulations, to avoid excessive flexion, which could worsen the instability. In severe cases, the subluxation can become significant enough to compress the spinal cord, leading to neurological symptoms such as weakness, numbness, and even paralysis. In extreme cases, this can be fatal. For example, in this pathological specimen from a patient who died of the C1-C2 subluxation, you can see that the odontoid process, which is the bony projection of C2, has subluxed posteriorly, severely compressing and almost severing the spinal cord. This highlights why early recognition and management of the cervical spine involvement in the rheumatoid arthritis is so important. And just for the sake of completion, Other joints can also be involved, including the temporomandibular joint, the cricoarytenoid joint, and the sternoclavicular joints. The cricoarytenoid joint is responsible for the abduction and adduction of the vocal cords, and involvement of this joint may lead to a feeling of fullness in the throat, hoarseness, and rarely, when the cords are essentially fused in a closed position, acute respiratory distress with or without stridor. So now that we have covered how rheumatoid arthritis affects the joints, let's move beyond that and talk about the extra-articular manifestations. Because RA isn't just a disease of the joints, it can involve the entire body. Many patients experience systemic symptoms like fatigue, fever, and weight loss, which are common with chronic inflammations. But interestingly, the more specific extra-articular features tend to be seen in patients who test positive for rheumatoid factor and anti-ACPA antibodies. Starting with the skin, one of the most well-known findings in the rheumatoid arthritis is subcutaneous nodules. These are firm, non-tender bumps that typically appear over bony prominences, extensive surfaces, and pressure points, especially the forearms and elbow. Apart from these nodules, skin fragility can occur, which can make patients more prone to bruising, particularly if they are on the long-term steroids. Rheumatoid arthritis can also cause small vessel vasculitis, which may present as digital infarcts, which are tiny areas of dead tissues in the fingers or toes, or as leukocytoclastic vasculitis, which leads to purple rash-like skin lesions due to blood vessel inflammation. In some cases, patients develop pyoderma gangrenosum, which is a rare but serious inflammatory skin disorder. It starts at painful pustules that quickly ulcerate, leaving deep necrotic sores with a purplish border. Unlike an infection, antibiotics don't help, and treatment usually involves immunosuppressive therapy. Now moving on to the cardiovascular system, rheumatoid arthritis significantly increases the risk of coronary artery disease and heart failure. Chronic inflammation accelerates the atherosclerosis, meaning the plaques develop faster in the arteries, increasing the risk of heart attacks and strokes. When you add in the factors like obesity, smoking, steroid use, and sedentary lifestyle, the risk multiplies. Beyond coronary artery disease, the inflammation in the rheumatoid arthritis can also affect the heart's outer lining, leading to pericarditis, which can cause chest pain and fluid accumulation around the heart. In some cases, when this pericarditis is long-standing, it can lead to fibrotic scarring of the pericardium, restricting the heart movement and leading to constrictive pericarditis. There is also an increased risk of blood clots, vasculitis, and even heart valve disease, though these are rare. The lungs are also commonly affected organ in the rheumatoid arthritis. Patients can develop pleural effusions, in which there is a buildup of fluid around the lungs, which can lead to shortness of breath. The lung tissue itself can also become inflamed, leading to interstitial lung disease, which can cause progressive scarring and stiffness of the lungs. This is one of the most serious complications of rheumatoid arthritis because it can lead to irreversible lung damage. In addition, the rheumatoid arthritis can also cause bronchiolitis obliterans, a condition where the small airways become narrowed and obstructed, making it harder to breathe. Rheumatoid nodules can also form in the lungs, which are benign but can sometimes be mistaken for lung cancers on chest X-ray or other imaging. The eyes are another area that the rheumatoid arthritis can affect. The most common issue is dry eyes caused by secondary Sjogren's syndrome, which is also known as keratoconjunctivitis sicca, where the immune system attacks the tear-producing glands. Beyond dryness, some patients can develop episcleritis, scleritis. In rare cases, the inflammation can cause scleromalacia perforans, where the sclera becomes so thin that it can perforate, leading to a severe loss of vision. Another serious issue is peripheral ulcerative keratitis, a destructive corneal inflammation that can thin the cornea and even cause perforation, which is a medical emergency. Neurologically, the rheumatoid arthritis can cause nerve entrapment syndromes, the most common being the carpal tunnel syndrome, where the median nerve at the wrist is compressed, leading to numbness, tingling, and weakness in the hands. Other nerves can also be affected, like ulnar nerve at the elbow or the tibial nerve in the foot, leading to conditions like tarsal tunnel syndrome. One of the more serious neurological complications is cervical myelopathy, which happens when the C1 C2 subluxation compresses the spinal cord, that we have discussed already. This cervical myelopathy can lead to weakness, numbness, and even paralysis if left untreated. In some cases, the patients develop mononeuritis multiplex, which is a condition where multiple nerves in different areas stop functioning due to vasculitis, leading to severe pain, weakness, and sensory loss in the multiple limbs. Rheumatoid arthritis can also lead to peripheral neuropathy. The hematopoietic system is also affected. Patients can develop anemia of chronic disease. Patient can also develop iron deficiency anemia due to the gastrointestinal blood loss from NSAIDs or steroids, which are the drugs that are used in the treatment of rheumatoid arthritis. Rheumatoid arthritis can also cause thrombocytosis, lymphadenopathy, and a very concerning complication called Felty syndrome, which is a triad of rheumatoid arthritis, splenomegaly, and low neutrophil count neutropenia. This increases the risk of recurrent infections and even blood cancers like leukemia. In the kidneys, the rheumatoid arthritis can lead to amyloidosis and vasculitis. And finally, the rheumatoid arthritis increases the risk of osteoporosis and osteopenia. Chronic inflammation itself disrupts the bone metabolism, making the bones weaker. Long-term steroid use can also accelerate the bone loss. And since many patients experience reduced physical activity due to joint pain, the lack of the weight-bearing exercise worsen the problem. This makes fractures more likely, so the bone health should always be monitored in patients with rheumatoid arthritis. So, as you can see, the rheumatoid arthritis is much more than just joint pain. It's a systemic disease that can affect multiple organ systems, leading to severe complications if not properly managed. That's why early diagnosis, aggressive treatment, and ongoing monitoring are so important. Not just to preserve the joint function, but to protect overall health and improve the quality of life for people living with rheumatoid arthritis. Okay, so let's talk about how the rheumatoid arthritis is diagnosed. Since modern treatment strategies focus on the early and the aggressive interventions with disease-modifying drugs, catching the rheumatoid arthritis as early as possible is crucial for better long-term outcomes. But diagnosis rheumatoid arthritis isn't as simple as ordering a single test. There is no definitive test that confirms it outright. Instead, diagnosis is based on a combination of factors including the patient's history, physical examination, laboratory tests, imaging, synovial fluid analysis, and lastly, the American College of Rheumatology and the European League Against Rheumatism classification criteria for rheumatoid arthritis. Okay, first, the history is crucial. A patient with rheumatoid arthritis typically presents with symmetrical joint pain, stiffness, and swelling that has been gradually worsening over weeks to months. The hallmark is morning stiffness lasting more than an hour, which improves with activity. The patient may also experience extra-articular symptoms like dry eyes, skin nodules, and shortness of breath, which could indicate a lung involvement. The history should also include risk factors like smoking or family history of autoimmune diseases. Next comes the physical examination. Here we look for joint swelling, tenderness, and warmth. particularly in the metacarpophalangeal and the proximal interphalangeal joints of the hands and the metatarsophalangeal joints of the feet, and other synovial joints like knees, ankles, hips, etc. Characteristically, the rheumatoid arthritis spares the distal interphalangeal joints and the small joints in the toes. As the disease progresses, we may see deformities like ulnar deviation, swan neck deformity, or Bottonier's deformity. We can also look for extra-articular manifestations like rheumatoid nodules, vasculitic lesions, or eye lesions, which can suggest more severe disease. Apart from these, patients may also have systemic features like fever, fatigue, and weight loss. What about the lab investigations? The laboratory findings play a crucial role in diagnosing and assessing the rheumatoid arthritis, with the most important being the presence of autoantibodies. One of the key autoantibodies is rheumatoid factor, which is found in about 75% of the patients with rheumatoid arthritis. Its presence is linked to more severe joint involvement and a higher likelihood of extra-articular manifestations such as lung disease or vasculitis. However, the rheumatoid factor is not specific to the rheumatoid arthritis. It can be seen in a variety of conditions that cause chronic immune system stimulations, including chronic infections or other autoimmune disease, and even in some healthy elderly individuals. The second and more specific autoantibody is the anti-cyclic citrullinated peptide antibody, also known as ACPA. It is detected in about 70% of rheumatoid arthritis patients. It has a very high specificity of about 93 to 98%. What makes the ACPA particularly useful is that it can be present years before the clinical symptoms of rheumatoid arthritis appear, making it a valuable marker for early detection. Additionally, the ACPA positive patients tend to be more aggressive and erosive, leading to greater joint damage over time. But here is an important caveat that about 15% of the patients with rheumatoid arthritis test negative for both the RF factor and the ACPA. This condition is known as the seronegative rheumatoid arthritis. And while these patients still meet clinical criteria for rheumatoid arthritis, they tend to have a slightly different disease course, sometimes with less extra-articular manifestations. Besides the rheumatoid factor and the ACPA, other autoantibodies are occasionally seen in rheumatoid arthritis, including the anti-nuclear antibodies and the anti-neutrophil cytoplasmic antibodies, particularly the perinuclear type. However, these antibodies are not specific to the rheumatoid arthritis and are commonly seen in other conditions like lupus or vasculitis. So, while autoantibodies are a crucial part of rheumatoid arthritis diagnosis, they are not the sole determining factor. Apart from the autoantibodies, patients with rheumatoid arthritis can have anemia of chronic disease, and the degree of anemia is proportional to the activity of the disease. Therapy that controls the disease will normalize the hemoglobin levels. Other causes of anemia in rheumatoid arthritis include iron deficiency anemia from gastrointestinal blood loss, especially with the concomitant use of NSAIDs. Patient can also have thrombocytosis, that is elevated platelet count, and the platelet count returns to normal as the inflammation is controlled. In patients with rheumatoid arthritis, the white blood cell count can be normal or it can be elevated. It can also be decreased in the syndrome called Felty syndrome, which is a triad of rheumatoid arthritis, splenomegaly, and neutropenia. Acute phase reactants such as ESR and the CRP levels parallel the activity of the disease, and their persistent elevation portends a poor prognosis in terms of both joint destruction and mortality. Patient can also have elevated eosinophil counts. Another clinically very important feature is the radiographic appearance of rheumatoid arthritis. It can easily be remembered by the mnemonic ABCDES. This will help you remember the key radiographic features of rheumatoid arthritis in a systematic manner. So starting with the A stands for alignment with no ankyloses. In rheumatoid arthritis, the joints loses their normal alignment due to chronic inflammation, ligament damage, and joint destruction. However, a key feature is that the rheumatoid arthritis does not cause bony fusion, that is ankylosing, in the early stages, unlike diseases such as ankylosing spondylitis. Instead, you see subluxation, joint misalignment, and deformities as the disease progresses. B stands for bones, periarticular osteoporosis, but no osteophytes. One of the earliest radiographic changes in the rheumatoid arthritis is periarticular or juxtaarticular osteoporosis. It occurs due to the chronic inflammation and increased blood flow around the affected joints, leading to bone resorption. You won't see osteophytes, that are the bony spurs, which are classic for osteoarthritis. In osteoarthritis, the bone reacts by forming new bone osteophytes, whereas in the rheumatoid arthritis, the bone is progressively lost. So this is a very key feature of differentiating between rheumatoid arthritis and osteoarthritis. The C stands for cartilage symmetrical joint space loss with no calcification. Rheumatoid arthritis is a polyarthritis that symmetrically involves the joints, meaning both sides of the body are affected in a similar pattern. The joint space narrowing seen in the RA is uniform across the joint because of the inflammatory process affects the entire synovial membrane, leading to diffuse cartilage destruction. In contrast, the osteoarthritis causes asymmetrical joint space loss, meaning one side of the joints wear down more than the other. Another important point is that the rheumatoid arthritis does not cause cartilage calcification or soft tissue calcification, unlike conditions such as pseudogout. Okay, the D stands for deformities with symmetrical distribution. As the disease progresses with chronic joint damage and ligamentous instability, leads to the characteristic deformities. Some of the classical ones are swan neck deformity, boutonniere's deformity, Z deformity of the thumb. Coming towards the E stands for erosions, marginal erosions. One of the hallmark features of rheumatoid arthritis is marginal erosions. This occurs because the pannus, which is the inflamed synovial tissue, aggressively invades the bone at the margins of the joint, where there is no protective cartilage. These erosions appear as small punched out areas near the joint line, especially in the metacarpophalangeal joint, the proximal interphalangeal joints, and the metatarsophalangeal joints. Over time, they contribute to the joint instability and deformities. And lastly, the S stands for soft tissue swelling. There can be nodules without calcification. Soft tissue swelling in the rheumatoid arthritis is due to the synovial inflammation, effusions, and hypertrophy. One important extra-articular feature of RA is rheumatoid nodules, which are firm, non-tender subcutaneous nodules which are found on the extensor surfaces of the forearm, elbows, and fingers. Unlike nodules in conditions like gout, the rheumatoid arthritis nodules do not have calcium deposition, meaning they do not show calcification on X-ray. So in summary, the ABCDES of the rheumatoid arthritis imaging gives us a structured way to remember its key radiographic features. To recap, they are misalignment without ankylosis, periarticular osteoporosis, symmetrical joint space loss, classical deformities, marginal erosions, and lastly the soft tissue swellings with nodules but without calcification. Now let me explain some of these features by radiographic imaging. This is a radiograph of the metacarpophalangeal joints showing a progressive marginal erosion of the metacarpophalangeal joint. This radiograph of the hands shows early rheumatoid arthritis with symmetrical joint space narrowing and juxta-articular osteoporosis. This is the X-ray of the same patient 5 years later with significant marginal erosions and severe wrist involvement. This is a radiograph of a severe rheumatoid arthritis showing destruction of the metacarpophalangeal joint, subluxation of the metacarpophalangeal joints leading to ulnar deviation, and also marked wrist involvement. Alright, let's now turn our attention to the synovial fluid analysis in rheumatoid arthritis. It is a key diagnostic tool that helps differentiate rheumatoid arthritis from other causes of joint inflammation. When we analyze the synovial fluid, we are looking at some of key parameters. The white blood cell count in the rheumatoid arthritis typically falls in the range of 5,000 to 50,000 cells, indicating an inflammatory but non-infectious process. However, in some cases, the white blood cell count can be above 50,000, which is termed pseudo-septic arthritis. This means that although the fluid appears highly inflammatory, almost mimicking a septic arthritis, there is no actual infection. In such cases, it is crucial to rule out true septic arthritis, which can rapidly destroy the joint if not properly treated. If a patient presents with a very high WBC count in the synovial fluid and severe joint symptoms, urgent gram stain cultures and possibly joint aspiration should be performed to exclude a bacterial infection. The dominant white blood cells found in the rheumatoid arthritis are the polymorphonuclear leukocytes, which are also seen in other inflammatory arthritis like gout or pseudogout. The protein levels in the fluid are generally elevated, reflecting the ongoing inflammation. Similarly, the glucose levels in the synovial fluid is lower than in the serum because the inflammatory cells consume glucose at the site of inflammation. One key distinguishing feature of rheumatoid arthritis synovial fluid is the absence of crystals, which helps differentiate it from gout or pseudogout. Similarly, the bacterial cultures in the rheumatoid arthritis synovial fluid are negative, which helps differentiate it from the septic arthritis. So in summary, the rheumatoid arthritis synovial fluid is inflammatory with moderate to high WBC count, predominantly the neutrophils, high protein, low glucose, no crystals, and definitely negative cultures. I hope all of you are with me. Now let's go step by step through the 2010 American College of Rheumatology and the European Union League Against Rheumatism classification criteria for the rheumatoid arthritis. This classification criteria is the gold standard for clinical trials and widely used as a diagnostic aid. This system was designed to identify the rheumatoid arthritis at an earlier stage, allowing for earlier intervention with disease-modifying therapies in order to prevent permanent disability. So in this classification criteria, the step 1 is, does the patient have at least one swollen joint? The first requirement in the criteria is that the patient must have at least one swollen joint, and the swelling should be evident not just from the patient's history, meaning that they feel pain or stiffness, but also on the physical examination, where we should see tenderness, warmth, and synovial swelling. If a patient does not have any swollen joints with active inflammation, we cannot classify them as having rheumatoid arthritis. And we must consider other causes of joint pain such as fibromyalgia or osteoarthritis, etc. Now, what if the patient does have at least one swollen joint? Then the next question we must ask is, could this swelling be due to any other condition? There are many diseases that can mimic rheumatoid arthritis but are distinct in their nature. Some examples include psoriatic arthritis, gout or pseudogout, viral arthritis, or even in the SLE. If the joint swelling can be better explained by any of these diseases, then the rheumatoid arthritis is ruled out and we should not classify the patient as having rheumatoid arthritis. Now let's suppose a patient is having swollen joint which cannot be explained by any other disease. Then the next step is to check for the radiographic evidence of rheumatoid arthritis, particularly the marginal erosions on X-ray. Now, if a patient is having swollen joints which cannot be explained by other diseases, and we do an X-ray and there are no erosions, what happens next? Does this mean that the patient does not have rheumatoid arthritis? The answer is no. It just means we need to apply the scoring system to confirm the diagnosis. This scoring system assigns points based on the 4 categories, which I will explain in a moment. If a patient scores 6 or more points, they meet the classification for the rheumatoid arthritis. And now the last scenario is a patient having a swollen joint which cannot be explained by other disease, and the X-ray show typical marginal erosions. We can directly classify them as rheumatoid arthritis. So to recap, the patient must have at least one swollen joint. The swelling should not be better explained by any other disease. If there are typical erosions on imaging, rheumatoid arthritis is confirmed. If no erosions are present, we use the classification scoring system to determine the diagnosis. Alright, let's dive deep into the ACR-UALAR classification scoring system for the rheumatoid arthritis. This is a systemic way to classify a patient as having rheumatoid arthritis, especially when the radiographic erosions are absent. Think of this scoring system like a point-based checklist where different clinical and laboratory findings contribute to the total score. A patient needs a score of 6 or more to be classified as having rheumatoid arthritis. There are 4 key parameters, each assigned a specific range of points based on the severity or extent of findings. These parameters include joint involvement with a score of 0 to 5, serology meaning autoantibodies with a score of 0 to 3 points, duration of symptoms 0 to 1 point, and acute phase reactants 0 to 1 points. Now let's break down each parameter one by one. So the number 1 parameter is the joint involvement. This parameter assesses how many and which joints are affected. The joints are divided into medium to large joints and small joints. The medium to large joints include knees, hips, shoulders, elbows, and ankles, while the small joints include metacarpophalangeal joints, the proximal interphalangeal joints, the metatarsophalangeal joints, and wrists. Okay, so the point distribution is as follows. If only one medium to large joint is involved, for example, just the knee, it is assigned 0 points. If 2 to 10 medium to large joints are involved, it is assigned 1 point. If 1 to 3 small joints, 2 points. And if 4 to 10 small joints are involved, it is assigned a value of 3 points. If more than 10 joints are involved, including at least one small joint, it is assigned a value of 5 points. This is important because the rheumatoid arthritis typically affects the small joints, and widespread involvement increases the likelihood of the disease. Moving on to the second parameter, that is serology. This refers to the presence of autoantibodies, including rheumatoid factor and anti-CCP or ACPA antibodies. Both of these antibodies support the diagnosis of rheumatoid arthritis, but their levels also matter. If both the rheumatoid factor and the ACPA are absent, it is assigned 0 point. If either rheumatoid factor or ACPA is positive at a low titer, that is about 1 to 3 times the upper limit of normal, it is assigned 2 points. If either rheumatoid factor or ACPA is highly positive, that is more than 3 times the upper limit of normal, then it is assigned 3 points. The presence of high titer of rheumatoid factor or ACPA is strongly associated with more severe and more erosive disease. So the next parameter is duration of symptoms. Here we look at how long the patient have active synovitis, meaning joint inflammation with symptoms of joint tenderness, swelling, warmth. If the symptoms have been present for less than 6 weeks, it is assigned a value of 0 point. But if the symptoms have been present for 6 weeks or more, it is given a value of 1 point. This criteria highlights that the rheumatoid arthritis is a chronic disease, and transient arthritis, which occurs for less than 6 weeks, may be due to viral arthritis or other self-limiting conditions. The last parameter is the presence or absence of acute phase reactants, which include ESR and C-reactive protein or CRP. These are markers of the systemic inflammation. If both ESR and CRP are normal, it is assigned 0 point. If either ESR or CRP is elevated, it is given 1 point. Rheumatoid arthritis is a systemic inflammatory disease, so persistently high inflammatory markers support the diagnosis. Now let's put this into practice with a clinical scenario. Imagine a 40-year-old woman comes to the clinic with pain and swelling in the metacarpophalangeal and the proximal interphalangeal joints of both hands for the past 2 months. Serology shows ACPA, that is of low positive value. The ESR and the CRP are normal. X-ray of the hand show no erosions. Now let's calculate her classification score. In the joint involvement, she is having metacarpophalangeal and the proximal interphalangeal joint of both hands, so 4 to 10 small joints involved, so the score will be assigned 3 points. In the serology parameter, the ACPA is low positive, so the score of 2 is assigned. In the duration department, she is having these symptoms for more than 6 weeks, so a score of 1. And lastly, the ESR and CRP are normal, so the score of 0 is assigned. So in this scenario, the total score is 3 plus 2 plus 1 plus 0 equals to about 6. Since her score is 6, she meets the criteria for rheumatoid arthritis. The 2010 ACR EULAR classification criteria allows us to diagnose the rheumatoid arthritis earlier, even before the irreversible joint damage occurs. The key takeaway is that the rheumatoid arthritis is not diagnosed by a single test. Instead, a combination of joint involvement, serology, inflammatory markers, and symptom duration is used to make the diagnosis. If a patient has a score of 6 or more on the classification criteria, rheumatoid arthritis is confirmed. If the score is lower, it doesn't rule out rheumatoid arthritis. But we need to keep the patient under observation and consider other causes of arthritis. By using this classification system, we can diagnose and treat the rheumatoid arthritis aggressively at an earlier stage, improving the long-term outcomes for our patients. So this was all about the diagnosis and the classification criteria for rheumatoid arthritis. Now, in the last and final chapter, we are going to discuss about the treatment of the rheumatoid arthritis. The treatment of rheumatoid arthritis is a combination of general measures involving various medical professionals as well as medication therapy and the treatment of underlying conditions and complications of rheumatoid arthritis. Coming to the general measure in the treatment of rheumatoid arthritis, as rheumatoid arthritis is a chronic, lifelong condition that cannot be cured, but it can well be controlled with the right treatment approach. A key part of the management is patient education and a multidisciplinary approach to improve the quality of life. Since RA is progressive, patients should be educated about their condition so that they can actively participate in their treatment. This includes managing joint stiffness by warm compresses, hot showers, and gentle activity can reduce the morning stiffness. Low impact exercises like swimming and yoga can improve flexibility. And using splints, braces, and ergonomic tools help reduce the joint strain. A physical therapist is also very important. A physical therapist teaches the range of motion exercises, muscle strengthening routines, and posture correction to maintain joint function and prevent deformities. Managing rheumatoid arthritis requires a team-based approach that includes a primary care physician who oversees the general health and screens for complications, a rheumatologist that leads the treatment plan, adjusts medications, and monitors disease progression, a rheumatology nurse that provides patient counseling, teaches various techniques, and helps monitor the drug side effects. Physical and occupational therapist guides on the joint protection, assistive devices, and daily activity modifications. And orthopedic surgeons manage severe joint damage with surgical interventions like joint replacements when needed. By integrating these general measures, we can help the patient preserve joint function, reduce the pain, and maintain independence throughout their disease course. So it is a very important part of the management of rheumatoid arthritis. Before moving on to the medical therapy used in the rheumatoid arthritis, let me talk about the goals of therapy in rheumatoid arthritis. The treatment of the rheumatoid arthritis aims to control symptoms, prevent joint damage, and improve patients' quality of life. Number one goal is to reduce or eliminate joint stiffness and prevent permanent damage. The second goal is to achieve disease remission. Remission is the ideal goal of rheumatoid arthritis treatment. It means that the disease is inactive or minimally active with no significant joint inflammation, pain, or progression of disease. The clinical remission is defined by strict criteria such as no swollen joints, no tenderness, normal inflammatory markers, and no morning stiffness. Remission is easier to achieve if the treatment is started early, ideally within the first 6 months of symptom onset. If complete remission is not possible, the next best goal is to achieve a very low disease activity. This means that minimal joint swelling and pain, but not complete absence of symptoms. Low levels of inflammation with low levels or mildly elevated inflammatory markers, and no significant progression of joint damage seen on X-rays. A patient with a very low disease activity may still experience occasionally mild symptoms, but the disease remains well controlled, allowing for a good quality of life and prevention of disability. So the earlier the treatment, the higher the chances of achieving remission or low disease activity. Okay, coming toward the treatment of rheumatoid arthritis, three main categories of drugs are used in the rheumatoid arthritis. These include non-steroidal anti-inflammatory drugs, NSAIDs, number 2, glucocorticoids, and number 3, the disease-modifying anti-rheumatic drugs, also known as DMARDs. The DMARDs are further classified into three types: conventional, biologic, and targeted synthetic DMARDs. The rheumatoid arthritis treatment occurs in two distinct phases. Number 1 is managing acute flares using NSAIDs and glucocorticoids to quickly control the symptoms. And number 2, long-term remission and disease control using DMARDs with a short-term glucocorticoid bridge until the DMARDs take effect. Okay, let me talk about the role of the NSAIDs in rheumatoid arthritis. The NSAIDs are used only for the symptomatic relief. They reduce pain, swelling, and stiffness, but they do not slow the disease process or prevent the joint damage. Why don't NSAIDs alter the disease process? This is because the rheumatoid arthritis, it is an autoimmune disease where the immune system attacks the joints. The NSAIDs work by blocking the cyclooxygenase enzyme to reduce inflammation, but they do not suppress the immune system. Since they don't prevent the immune-mediated joint destructions, they are not disease-modifying. So NSAIDs help with the symptoms, but must be combined with the DMARDs for long-term disease control. Another important point is that the NSAIDs inhibits the prostaglandins which protect the stomach lining. This increases the risk of gastritis, ulcers, and GI bleeding. To prevent this, the NSAIDs should be used with the proton pump inhibitors like omeprazole, esomeprazole, or pantoprazole. The types of NSAID used in the rheumatoid arthritis include COX-2 selective inhibitors, which has a lower incidence of GI risk. These include celecoxib, less likely to cause ulcers but may have a higher cardiovascular risk. The other types are non-selective NSAIDs that block both the COX-1 and COX-2 enzyme. They have a higher GI bleeding risk. These include ibuprofen and naproxen. Naproxen has the lowest cardiovascular risk among the NSAIDs. The second class of drug used in the management of rheumatoid arthritis are glucocorticoids. They provide a rapid and dramatic symptomatic relief and also reduce the disease activity and slowing the radiographic progression of joint damage. They have a very quick onset of action, making them useful in acute flare-ups. However, for the long-term management, they should always be used with the DMARDs and for the shortest duration possible. Glucocorticoids are used in three types of settings. Number one, for acute flare-ups, they help control inflammation quickly. They can also be used as a bridging therapy used alongside with DMARDs while waiting for the DMARDs to take the full effect. And they can also be used for extra-articular manifestations like vasculitis or scleritis. An example is the prednisone 5 mg per oral once a day is commonly used. An important point is that higher doses of glucocorticoids are used for the extra-articular manifestations like vasculitis or scleritis. All patients on the long-term steroids must get osteoporosis prophylaxis, especially with the bisphosphonates, for example, alendronate or risedronate. Calcium and vitamin D supplementations is also recommended, and to monitor their bone mineral density regularly. So, to summarize, the glucocorticoid provides fast relief, but they should be used for the shortest time possible. Higher doses are needed for vasculitis or scleritis. Always combine them with DMARDs and aim for the low dose or no steroids in the long run. And lastly, osteoporosis prevention is a must when using steroids long term. So here comes the final chapter of our discussion, the disease-modifying anti-rheumatic drugs. The DMARDs are the backbone of rheumatoid arthritis treatment as they halt disease progression, prevent joint destruction, and slow the radiographic damage. They are divided into conventional DMARDs, biologic DMARDs, and targeted synthetic DMARDs. Let me first talk about the conventional DMARDs. These drugs take 2 to 6 months to achieve their full effect and are effective in both early and the advanced rheumatoid arthritis. The choices depend on the patient's concern, toxicity profile, comorbidities, and the disease activity. The conventional DMARDs include methotrexate, hydroxychloroquine, leflunomide, sulfasalazine, azathioprine, and minocycline. Methotrexate is the first-line DMARD. It is most effective initial DMARD and it improves outcomes and enhances the effects of other DMARDs as well. It is cost-effective with rare serious toxicities. Contraindicated in the pregnancy and significant renal impairment. The common side effects of methotrexate include oral ulcers, nausea, hepatotoxicity, bone marrow suppression, or pneumonitis. If the methotrexate alone is insufficient, it can be combined with other DMARDs, for example, hydroxychloroquine, leflunomide. Now, what about the biological DMARDs? These target specific immune pathways and are used when the conventional DMARDs fail. The classes of biological DMARDs are TNF, tumor necrosis factor inhibitors, including infliximab, adalimumab, and etanercept. There are also interleukin-6 inhibitor like tocilizumab and CD20 B-cell inhibitor rituximab. The important consideration with the biological DMARDs are increased risk of infections, especially the atypical infections. It is also mandatory to screen for latent TB before starting therapy. Never combine two biologic DMARDs. This leads to a high risk of infections. And one important thing is that it must be managed by a rheumatologist. And last but not the least, the targeted synthetic DMARDs. These are JAK inhibitors used when other DMARDs fail. These include tofacitinib, baricitinib, and upadacitinib. These are all oral options, unlike biologics, which are injectables. They have a similar increased risk as biologics, requiring careful monitoring. So the key takeaways are DMARDs slow disease progression and prevent joint destruction. Methotrexate is the first-line drug and works well alone or in combination with other drugs. Biologic DMARDs are used when the conventional DMARDs fail but require TB screening and infectious monitoring. The targeted synthetic DMARDs, JAK inhibitors, are the newer options with serious infectious risks. So finally, that wraps up our discussion on rheumatoid arthritis. I hope this video provided you with valuable insights into rheumatoid arthritis management and its latest treatment strategies. If you found this video informative, please like, subscribe to the channel and share it with others who might benefit from it. Your support helps us create more high quality medical content. Take care and see you in the next video.